All right, thank you, Natasha. I appreciate the introduction and thank you everyone for joining us for our lecture. Um, Happy to talk about this during February, which is Heart Month, and thought we would talk about hypertension as our topic. I chose this topic obviously because of the widespread implication and also because I think there are some things we can learn on detection, some programs that are available here at Barton. I also chose to talk about the lifestyle modification and some of the supplements that are used for managing hypertension. I didn't in this talk go into as much of the pharmaceuticals and therapy for hypertension because that's probably a whole nother lecture that I'd be happy to give you at any time. So let's get started here. Let's talk a little bit about the scope of the problem. So hypertension is very common and affects about 72 million Americans and about 1 billion people worldwide. And the disturbing thing about hypertension is when we talk about all these cardiovascular conditions that we're trying to prevent, such as myocardial infarction, known as heart attack, strokes, heart failure, atrial fibrillation, and peripheral artery disease, that hypertension is the most common risk factor and it's identifiable and potentially reversible for all of these conditions. Also, when we get into this age of rising levels of obesity and people living to longer ages, we're going to see more of a burden of hypertension in the global community. And in fact, by next year, about a third of the world's population will be affected with the diagnosis of hypertension. And it has already become the leading cause of potentially preventable death in the world, exceeding smoking. So what exactly is hypertension? Well, for most of us, hypertension is defined as a blood pressure that's greater than 140/90. And why do we make that definition? Well, in randomized clinical trials, we can tell that the benefit of pharmacotherapy really starts to document its effect above blood pressures in this range. However, I will tell you that there's a lot of controversy with this blood pressure determination because we find as soon as blood pressure increases over a value of 115/75, that we start to almost have a curvilinear increase in events like coronary artery disease, which can lead to heart attack, as well as stroke. So what causes hypertension? Well, there's certainly a genetic component to it. Many of you may know, well, my parents had hypertension, or I have a brother that has hypertension. So certainly there is genetic linkage there. But unfortunately, the major component to hypertension in our society is behavioral determinants. Of one of these is nicotine. So every time a person smokes a cigarette, your blood pressure can increase by 10 to 20 points. Excessive alcohol consumption is also common. Anyone that engages in more than 3 drinks in an evening will certainly have a rebound effect of hypertension the following day. In today's society of physical inactivity, which leads to obesity and negates the cardioprotective effects of exercise. Diets, particularly ones that are rich in processed foods or low in fresh fruits, vegetables, fiber. Many of these contain vitamins and minerals, which are important in maintaining normal intensive blood pressure readings. We also live in a society of excess calorie consumption. Average American will eat 3,600 calories a day, but may only require 2,000 to 2,500 for what they need to maintain their body, which leads to obesity. And probably one of the biggest determinants is the amount of sodium that we take in our diet. So what are the different mechanisms of hypertension? Well, these are really the two, and listed a third category that we tend to see in our office. The first is what we call diastolic hypertension in middle age. This usually is in a 30 to 50-year-old individual, and we tend to see it more in males than females. This happens with some centralized obesity, a little weight gain, and then you start to notice that there's a creep up in the diastolic blood pressure reading. Remember, there are two parts of your blood pressure. There's a systolic reading, which is the top number, which represents the peak blood pressure, the peak pressure through your blood vessel, and also a diastolic blood pressure, which is the bottom number, which represents the pressure in the blood vessel while the heart is relaxing for the next heartbeat. So in this age group, we start to see a creep up of the diastolic reading. And if this isn't corrected through aggressive lifestyle modification or potentially medication, then we tend to see a follow in the increase in the systolic and top number. And once both the systolic and the diastolic are elevated, we tend to call this classic essential hypertension. Hypertension has two broad categories. There's 95% of the people which have essential hypertension or primary hypertension. And then there's a subset of about 5% in a category called secondary hypertension, which has a number of different clinical conditions, potentially reversible, which can lead to it. So diastolic hypertension in middle age is our first category. But as we get older, our blood vessels start to stiffen and they don't relax as well. And when the heart pumps the blood forward and the blood vessel doesn't relax to expand to account for that increased volume, then it causes a spike in the systolic blood pressure with a drop to the diastolic blood pressure. So we call this isolated systolic hypertension in older adults. And again, this is due to stiffening of the blood vessels. By the age of 75, about 90% of us will develop this isolated systolic hypertension due to stiffening of our blood vessels. There is a third category which I just wanted to mention, but not to spend too much time on. It's called isolated systolic hypertension in the young adult. This really occurs in younger individuals and is more related to a stiffening of the aorta, which is a main blood vessel in the chest. I just wanted to mention this as a category, but I don't think it's important to focus too much more time on it other than that. So what symptoms do people have with hypertension? Well, the problem is many have none. Hypertension is called the silent killer because your blood pressure can be elevated and you can be entirely asymptomatic. But you can be asymptomatic if it's not detected for long periods of time, which can lead to a lot of damage to your organs. So what is that damage? Well, we can start with the brain and start with stroke. So there are different kinds of strokes that can be caused by hypertension. You can develop damage to the blood vessels leading to the brain, which can lead to what we call an ischemic stroke. You can develop aneurysms in the brain, which can burst and then bleed, and you can have a hemorrhagic stroke. It can also affect the blood vessels that go to your eyes and can cause blindness, which we call a retinopathy. For your heart, there are a couple of things that can develop. One is because the heart has to pump against that high pressure, the muscle of the heart has to get stiffer and thicker to squeeze harder to circulate the blood. And over time, that thickened and stiffer heart can have more and more difficulty relaxing, which can cause the heart to have to fill at higher pressures to distend that muscle, which can then congest backwards and give you congestive heart failure. It can also cause damage to the blood vessels that surround the heart. Your heart's like a muscle. It needs blood, oxygen, nutrients to function properly. And these arteries that surround the outside of it are called your coronary arteries. And over time, that hypertension can accelerate plaque deposition in those arteries, which can eventually lead to a heart attack. It can damage your kidneys and can lead to conditions such as end-stage kidney disease and potential need for dialysis. And again, it can lead to arterial sclerosis anywhere in the body, which is plaque formation in the arteries obstructing blood flow. But high blood pressure can have some symptoms depending on how high it is. Many times we see people with what's called a hypertensive urgency or emergency when their blood pressure is very high, say at a systolic value of greater than 180. And this can cause dizziness, headaches, blurring in your vision, nosebleeds, can cause heart rhythm disturbances known as arrhythmias, can lead to fatigue, swelling in the legs, difficulty breathing, chest pain, chest pressure, which is also known as angina. Many times these patients with these type of symptoms and high blood pressure are seen in our emergency room for acute therapy. So how do we diagnose hypertension? Well, for the vast majority of people, this will be accomplished at your doctor's office. That's why it's so important for everyone who's at an age, say over 65, where we have this higher incidence of this isolated systolic hypertension, to have annual wellness visits performed where we can detect this. Usually you will go into your physician's office and you will have a blood pressure taken when you're seated in a chair with your back supported, and ideally after resting for several minutes. You should always have your blood pressure taken on a bare arm at heart level. If your blood pressure is elevated, you will usually be asked to sit and relax for 5 minutes and then have a repeat blood pressure measurement taken. In order to diagnose hypertension in the office, we usually like to have 2 or more readings that are taken at least 5 minutes apart at least 2 different office visits. One of the problems that I found in clinical practice is that sometimes your blood pressure reading in the office just doesn't really accurately reflect what's going on at other times. Say you're late for your appointment and rushing in, you're anxious about your appointment, you're running upstairs to your appointment, and many times people just don't have the 5 minutes to sit and rest to make sure that we get an adequate blood pressure reading. So I'm a very big proponent of what we call home blood pressure monitoring. And I think this is the only way to really obtain a clear and accurate representation of a patient's usual blood pressure. In fact, it's been documented that this is a more predictive way of measuring blood pressure for predicting cardiovascular events than relying on office recordings alone. And the reason is there's a condition called white coat hypertension, which many of you have heard of. And these are the individuals that, for whatever reason, the anxiety of an office visit or seeing a physician, many times it's subpsychological, just leads to a spike in their blood pressure. So they will have substantially higher blood pressure readings in the office compared to what they may have at home. And if you overreact to that and start to medicate their in-office readings, then that can lead to periods of low blood pressure at home, which could potentially be just as dangerous. So when we do home blood pressure readings, I have a specific protocol that we utilize in cardiology. I always like patients to do the blood pressure first thing in the morning. And why do we do it in the morning? Well, your blood pressure is usually lowest at night, and then when you wake up, you have a sharp spike in your blood pressure. And this is mainly due to the stress of awakening, increased cortisol levels in the morning, which is in fact why most heart attacks occur early in the morning as well. Throughout the day, you have sort of a consistent rise in your blood pressure, and then it usually peaks somewhere between 4 to 6 p.m. and then starts to decline over the evening. So that's why we do the morning blood pressure, to try and catch that early peak in the morning. I always tell patients I need you to get out of bed, go to the bathroom to empty your bladder, because having a full bladder can elevate your blood pressure as well. Find a nice calm place in the house without having any caffeine, watching the news, eating any food, doing anything which may potentially stress you out. Sit in a chair comfortably for 5 minutes, take some deep breaths, lay your arm out on a table, make sure it's a bare arm, your feet are on the floor, your back is supported, and take your blood pressure recording on your left arm. I usually have patients wait a couple of minutes and take a second recording and then send me that information. One of the things that we do preach a lot is it's very important to get the right monitor. I have found that as we've engaged in this home blood pressure monitoring, that the wrist devices just aren't as accurate as a arm blood pressure cuff. And I think it's just simply due to the fact that you're trying to measure blood pressure in an artery that's the size of a spaghetti noodle compared to the much larger brachial artery, which is up into the bicep area. So I always advise people to get an arm cuff and trying to avoid the wrist cuffs as much as possible. Many of these home blood pressure monitors have actually been validated. I tend to recommend Omron as a potential outpatient company. There is also another company called QArdio, which has a validated device. So making sure that there is some documentation of validation can be important as well. I will also tell you that the size of the cuff is critically important as well. If you're an individual that has a large arm and you put too small a blood pressure cuff on there, that's going to falsely elevate your blood pressure. If you're an individual with a small diameter arm using a large blood pressure cuff, that will falsely lower your blood pressure, giving you inaccurate readings. It is always important that if you're measuring your blood pressure at home, to bring in your device to the office so we can check it against manual recordings. I will have patients a lot of times purchase the blood pressure cuff, save the receipt, contact me, come into the office, we'll check their blood pressure with the manual recording, check it immediately with their arm blood pressure cuff, the purchased cuff they have for home, and make sure that the two readings are right. And of course, if it's not, then you can take it back and return it. There are several programs we have here at Barton to assist individuals in our community to measuring your blood pressure. And I think individuals should take advantage of this. There is a grant, or through the foundation, we have the ability to provide people blood pressure monitors, home blood pressure monitors we can provide to patients. These individuals just need to contact their primary care office and they will schedule a 30-minute visit where they will have their blood pressure checked, discuss their medications, lifestyle, go through all of the risk factor modification that we need, as well as to provide them with a blood pressure monitor. We also have blood pressure clinics, and these do not need appointments. There are scheduled dates that you see below, the first and third Wednesday of each month, 8 to 12 and 1 to 4, performed at the Center of Orthopedic Wellness, where you can come in and a spot check, have your blood pressure checked. Can also bring in your monitor at these time frames to also have them checked against a manual recording to make sure they are accurate. Many of our providers are also engaging in a Brilliant Care program, which we have partnered with for our Medicare population. As a physician, if I'm seeing a patient in an office and your blood pressure is elevated, it will automatically prompt me to see if you want to be enrolled in this program. And Brilliant Care is an outside company that we contract with, where we enroll you, usually at a cost of $12 to $30 a month, but sometimes can be totally cost covered depending on your insurance, where you will be automatically shipped a device, an automatic device to monitor your blood pressure. And this device has cell phone capacity, so you don't need Bluetooth or Wi-Fi or any login like that. And it will automatically transmit the blood pressure that you take once a day to this Brilliant Care company. There will also be a nurse that if you don't take your blood pressure, will call you that day to remind you to take that recording. And then those recordings are then relayed to your healthcare provider, which gives us a continuous summary of your blood pressure readings. So again, we can track very accurately those home blood pressure recordings to make determination on, do you need medication? Are your medications sufficient? You will also have at least a monthly check-in call with your nurse, who is assigned to you from your office. And certainly if we are having lability or unstable blood pressures, we can address those on a more frequent basis. We also usually tend to keep these for about 3 months of stability in blood pressure. So after we know we keep your blood pressure very well controlled, then this service can be discontinued. So what happens? So we've talked about all this. You went into the office, your blood pressure was elevated, and we got a home blood pressure monitor, or you went through one of the programs that are offered here at Barton, and your blood pressure is high. Well, what do you do about it now? These are the common questions I get. Well, I don't really want to take medications. What lifestyle changes do I need to make? And many people will say, well, I don't want to take pharmaceuticals. Is there any over-the-counter supplements that can help me with my blood pressures? And do I really have to take medication? Do I need it? You know, if I have to, what's the best medication for me? And will I be on medication forever? Well, some of that really depends on how bad your blood pressure is to begin with. So the American Heart Association has these different stages of blood pressure. And again, here's some of that controversy that I described before. So they describe a normal blood pressure as less than 120 systolic and less than 80 diastolic. They consider an elevated blood pressure, 120 to 129, and a high blood pressure stage 1 reading of 130 to 139 systolic or 80 to 89 diastolic. You then get into stage 2 hypertension, which is a 140 or higher systolic, 90 or higher diastolic, and then they consider a hypertensive crisis. Again, one of those elevated blood pressures associated with symptoms that we described earlier, with a systolic of greater than 180 or a diastolic greater than 120. So I'm going to focus primarily on elevated to stage 1 hypertension and a little bit into stage 2 hypertension, because most of us, if you come in with a blood pressure of greater than 180 or a diastolic greater than 120, generally tend to initiate medication immediately at that point. But I'm going to focus on those who we can try lifestyle modification and describe some of those methods that we can do to hopefully reduce blood pressure to normotensive levels. So the first thing I recommend is exercise. And it's interesting. I always sort of learn something as we get ready for these talks is we've always tend to prescribe aerobic exercise, swimming, jogging, bike riding, walking, and really telling everyone we want them to get at least 30 minutes of moderate intensity activity most days of the week. And we describe moderate intensity in a couple different ways. The most common is, you know, we want you to be working out hard enough where you're short of breath to the point that you couldn't sing a song. But if someone was walking alongside of you, that you'd be able to talk with them in complete sentences. That's sort of a moderate physical activity. But it turns out that we can get blood pressure drops with all other kinds of exercise, such as high intensity interval training or HIIT. That can lead to a 4.08 drop in systolic and a 2.5 point drop in diastolic blood pressure. We talked about aerobic activity, which is a 4.49 systolic drop and a 2.53 diastolic drop. Resistance training, 4.55 over 3.04 drop. But the thing that was the most interesting to me is of all these different exercises, it's now being published that isometric exercises, and an isometric exercise could be something like a wall plank or a squat, tend to have the biggest drop in blood pressure over time. Running, they decided, if you want to break it down a little bit further, aerobic exercise was the most beneficial for decreasing your diastolic blood pressure. But again, these isometric movements, these planks and wall squats, were the best for lowering both systolic and diastolic blood pressure. The second, of course, is smoking cessation. So smoking, nicotine is what we call a vasoconstrictor. So the nicotine, when it gets into your circulation, directly constricts the blood vessel. And your pressure in your blood vessel is a function of the flow, the blood moving through the blood vessel times the resistance. As you constrict down that blood vessel, you elevate the resistance and elevate the pressure. The good news is stopping smoking almost has an immediate curative effect. After 20 minutes after smoking, your heart rate and your blood pressure start to return back to normal levels. In addition, in 12 hours, the carbon monoxide, which is a competitor for your red blood cells and starves your red blood cells of oxygen to deliver it to tissues, starts to eliminate to your body and return to normal levels. In 2 to 3 months, your circulation and your lungs start to improve significantly. And in a year, your risk of heart disease after stopping smoking is half of that as someone who still continues to smoke. Weight loss is the next that comes up. And hypertension is twice as common in obese individuals as non-obese individuals. And there's been a lot of data that has been published that tries to correlate the degree of weight loss versus the drop in blood pressure. I tend to tell patients in the office to make a significant change in your blood pressure, you need to lose about 10% of your body weight. The larger the weight loss, the more profound the effect is. But for analytical data, if you lose about 5.1 kilograms, which is a little over 10 pounds, you can expect to see a 4.4 over 3.5 millimeter drop in your blood pressure. Another way of looking at this is that for every kilogram lost, you tend to lose about a point off your systolic and diastolic blood pressure. Kilogram is about 2.2 pounds. One of the other things that's emerged in our literature is the use of these injectable type 2 medications, which also have the ability to cause significant weight loss. Ozempic was the first one that we became familiar with. And although I don't prescribe these for weight loss or type 2 diabetes in our clinic, I have seen several patients who have utilized these medications who have had substantial weight loss, who has then led to significant drops in blood pressure. In fact, there are some published studies following about 500 individuals over a 30-week time frame who were defined as obese with a body mass index of greater than 30. There were 3 different doses of this medication, which is Zepbound. The lowest dose at 5 milligram led to a 7.4 millimeter reduction in systolic blood pressure, but that again was associated with a 15% weight reduction. The higher dose of 10 milligrams, 10.6 millimeter systolic reduction, and associated with even greater 20% weight loss. The highest dose, 15 milligrams, had sort of a static blood pressure drop, but you can see that appears to be closely correlated to sort of a static weight loss. So I think what's important to see out of this is that weight loss can be directly correlated to blood pressure dropping, and the more weight that is lost, the more profound the effect is. The third issue is diet. And if you ask anyone in the cardiovascular literature what the gold standard would be for hypertension management and diet, it's referred to as the DASH diet. Now, there are a number of other diets which have substantial cardiovascular benefit, such as a whole food, plant-based, low oil diet. But for the purpose of this talk, I've chosen just to talk about the DASH diet. The DASH diet stands for Dietary Approaches to Stop Hypertension. And the basis of this diet is that you're going to avoid foods that are high in saturated fats, in particular sodium. And you're going to increase your intake in foods that are rich in potassium, calcium, fiber, and protein. You're going to be very strict about your sodium and limiting the intake to less than 2,300 milligrams a day. Well, 2,300 milligrams a day sounds like a lot. I don't think I eat that much. Well, unfortunately, most people do. So the average American consumes about 3,500 milligrams of sodium a day. And people will tell me, well, I don't put salt on my food. I don't cook with salt. The amount of salt that you put on your food is insignificant to the amount of salt that is hidden in the average American diet. All of the processed food contains excessive amounts of sodium that are consumed almost unknowingly. So I put some examples on here. For example, a Yoplait yogurt may have 100 milligrams of sodium. French fries, obviously, you would expect to be high at 200 milligrams of sodium. Bag of pretzels, 250 milligrams. Slice of pizza, 700 milligrams. A canned soup can have at least 940 milligrams, if not higher. So there is hidden sodium in everything that we consume, which is very hard to extract and eliminate. Here's also some other examples of foods that are consumed that are excessive in sodium. We talked about soups. Deli meats is very common. Salad dressing, sandwiches. A lot of times people will say, well, I ate healthy for lunch. I had a turkey sandwich. And I try and explain to them, well, there's the deli meats, there's the bread, there's the cheese, there's the condiment, there's the pickles. All of that can add up. And before you know it, you've crossed 200 or 2,300 milligrams very easily. So what are some tips to reduce sodium? The first thing I tell people is always pick up the labels. When you go grocery shopping, flick over to look at the nutritional levels and read about the amount of sodium that's contained in that food. When you cook, try and use salt-free spices and flavorings instead of salt. Don't add salt, obviously, when you're cooking. Choose plain or fresh vegetables instead of frozen or canned vegetables. Choose fresh, skinless poultry, fish, and lean cuts of meat for your protein intake. And probably one of the biggest things is try and eliminate the amount of restaurant food, processed food, pre-prepared foods that you eat. The other thing I want you to be aware of is you do this, your food's going to taste a little weird for a while because you're so used to the high sodium content. And as you start to peel back that salt, the food's going to taste bland. But over time, your taste buds will adjust to that and reset. Next, I want to switch to alcohol because everyone will come in, well, I heard a glass of wine's protective for me. And, what if I have two? And, what if I have three? Or what if it's a bottle of wine a night? What damage is happening to me? And the problem is that it's a very slippery slope. Although there may be some benefits for very moderate amounts of alcohol consumption, it's almost outweighed by the potential negative effects of alcohol misuse. So when you consume alcohol from a direct physiologic effect, especially if we exceed more than 3 drinks in a day, we automatically lead to elevated blood pressure. That elevated blood pressure causes inflammation in our blood vessels, which can lead to plaque deposition, which we call arteriosclerosis. Alcohol is also a sugar and carbohydrate and a refined sugar, so it floods into our bloodstream and elevates our blood sugars as well as triglycerides. So we have direct physiologic effects from the alcohol, which can be harmful cardiovascularly. There's also behaviors that are affected by alcohol, such as maybe you don't want to work out as much, or you have decreased physical activity, can lead to poor dietary choices. The excess calories can lead to a higher body mass index. Sometimes people have a higher likelihood of smoking, poor compliance with therapeutic regimens. And both these behavioral factors that are induced as well as the direct cardiovascular effects can altogether lead for an increased risk of cardiovascular disease. So how much alcohol is good and do I need to cut it out? Well, we already know too much drinking can be directly tied to elevating your blood pressure. And it's been documented that having 3 more drinks a night raises your blood pressure temporarily initially. But if people continue on this heavy alcohol consumption pattern, and if not engage in binge drinking, which is defined below as 4 or more drinks in 2 hours for women and 5 or more drinks in 2 hours for men, this can lead to long-term damage and long-term consequences of hypertension. So in general, what are the recommendations? Well, we generally tell people if you're a heavy alcohol user, which is defined as 3 or more drinks per day, to cut back to moderate, which is 1 drink a day for women, 2 for men, and that will start to lead to a blood pressure drop of at least 5.5 points systolic and 4 millimeters diastolic. However, the overwhelming consensus is if you have high blood pressure, please try and avoid alcohol, or at the most have moderation in alcohol consumption, because you will notice a drop in your blood pressure. I also want to tell you that there's a lot of discrepancies in exactly what 1 drink is. So what's considered a drink? That's 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of an 80 proof distilled spirit, which is probably significantly less than what most people would consider. The other condition I want to talk about that's potentially reversible and may fix your hypertension is a condition called sleep apnea. So there are 2 types of sleep apnea. There's obstructive sleep apnea, where you have an occlusion in your airway. And then also another type of sleep apnea called central sleep apnea, where there's more of a miscommunication between the brain and the lungs. This can be very prevalent at high altitude. But just talking about obstructive sleep apnea, here's a diagram where you can see a normal airway on the left, where an individual is breathing in, nose going through the nose, through the mouth, and down into the airway unimpeded. But in obstructive sleep apnea, you can see that there is an occlusion where the posterior aspect of the throat here starts to occlude the airway. And this can be to all kinds of things due to a thick neck, a tongue falling back, a set back jaw. There's a number of different anatomical reasons for why people can have these obstructions. Well, what symptoms does this lead to? Well, perhaps one of the most common symptoms is your spouse or partner may hear you snore, stop breathing, choke, gasp in the middle of the night. But you may feel the consequence of this from your disrupted sleep cycle, leading to poor concentration, mood disorders, waking up in the morning with headaches, feeling tired during the daytime, irritability. The list goes on and on of potential complications. From a cardiovascular standpoint, what happens is if you're breathing and sleeping, and then all of a sudden you obstruct this airway, then your brain freaks out and has to wake up your body to restart that breathing process. And you have this drop in your oxygen saturation. And the part of your nervous system that does that is called your sympathetic nervous system. And that's where if you get scared or frightened and you start to feel your heart race and beat, that's your sympathetic nervous system being activated. So when you continually to have these periods of obstruction and your airway closes and your brain activates your sympathetic nervous system to wake you up, then that leads to a flood of these adrenaline-like hormones in your body, which then carry over the next day to maintain elevated blood pressure readings. The good news is this is treatable, although usually people aren't too happy when I tell them what the treatment method is. The treatment method is sometimes a CPAP or another device similar called a BiPAP, which then actually blow in air to keep that airway open and keep it from being obstructed. I commonly see hypertension in sleep apnea patients. In fact, about half the patients with hypertension have associated sleep apnea. This is also very common in individuals who we referred to us who are on 1, 2, 3 blood pressure medications and they can't keep their blood pressure controlled. We always tend to screen those patients for sleep apnea, and there's a high pretest probability that's the underlying condition which is causing the resistance. All right, so in our last section here, to recap, we've gone over the diagnosis of hypertension, how you monitor it at home, what lifestyle modifications you can make to reduce your blood pressure, and short of taking pharmaceuticals, which may be the end steps for some individuals, what are some other supplements that you can take or naturopathic ways to lower your blood pressure? One of the first that I get asked about is magnesium, because there's all kinds of marketing that magnesium is good for your heart. I will say that in most cases, that's true. In patients who have palpitations, sometimes I use magnesium as a supplement. It can be very effective. Unfortunately, it's not that conclusive for high blood pressure. There's been some information out there that taking higher doses of magnesium, such as 500 to 1,000 milligrams a day, may lead to a modest blood pressure drop. The theory is, and you'll see this with the other supplements, is that it may lead to production of a molecule in your body, which is called nitric oxide. Nitric oxide acts to dilate blood vessels, which can then lower blood pressure. The downside to magnesium, however, is the clinical data to support its use is just not very strong. So it is recommended to try and increase your magnesium intake naturally with foods such as almonds, peanuts, spinach, black beans, but taking high doses of magnesium supplementation, in addition to potentially causing diarrhea, which is a side effect of it, does not tend to lead to significant blood pressure drops. The next is vitamin D. And this is a really interesting dilemma because what we find is that a large percentage of patients who have hypertension also have low vitamin D levels. And it's really unclear as to whether that's just due maybe to physical inactivity, lack of sun exposure, which has led to the hypertension, or whether it's related to vitamin D. They've also found in a study of over 300,000 individuals that those who had the highest levels of vitamin D had a 30% lower risk of high blood pressure compared to those with the lowest vitamin D levels. So I always encourage our patients who have hypertension to have their vitamin D levels checked, but supplementing the vitamin D may not necessarily lead to blood pressure control, but is important for other aspects such as your bone health. Probably one of the most important nutritional supplements for your heart is potassium. And the reason is potassium competes with sodium to be resorbed in your body. So sodium, when it's resorbed, causes water to follow. And the more water you put into the blood vessel, the more flow there is, the higher the pressure will be. So consuming natural intake of potassium-rich foods and avoiding sodium-rich foods is very important for blood pressure health. And you can see on the right here, I've tried to include some common causes of potassium-rich foods. Now, I will tell you as a caveat, if any of you have kidney disease or kidney impairment, that you do need to be cautious about your potassium intake and speak with your nephrologist first. L-arginine is another supplement that I get asked about. L-arginine is amino acid that is involved in protein synthesis in your body, and it also can be involved in the production of nitric oxide. A lot of people who are into sports may use this as a supplement to vasodilate or dilate blood vessels to improve performance. And there is some evidence possibly showing that L-arginine can be associated with improved blood pressure control. The last supplement I want to talk about is beetroot. I think in all the supplements that I've seen that people have taken, particularly individuals who really don't want to take medications for their blood pressure, that beetroot and beet supplements have probably been the most productive in lowering blood pressure. And these beet substances are very high in nitrates, which is then converted to nitric oxide. And as we've described before, can be called a vasodilator or lead to dilatation of blood vessels to lower blood pressure. So what do? We've identified the blood pressure. We've taken our home blood pressure readings. We've tried our lifestyle modification. We've tried the beetroot or whatever supplement we could do. And you come back in for your follow-up and your blood pressure is still elevated. Well, then it may be time to talk to your primary care or your specialist about medication. I want to convey to you that medication is not always permanent. Just because you have to start a medication doesn't mean that it's going to last with you for the rest of your life. Continued aggressive lifestyle modification in some individuals can lead to cessation of blood pressure therapy. But again, the ultimate goal is, again, recognizing the risk of hypertension, its ability to be identified, treated, and prevent both the short and long-term complications of cardiovascular disease. With that, I think I'd like to stop and open up to any potential questions there could be.
Great. That was wonderful. Several of the questions that have been asked have been addressed, but I just will ask it one more time for those that might have tuned in a little bit later. Just asking again, maybe your top recommended foods to avoid and top recommended that people should look to eat if they have high blood pressure.
Yeah, well, I think the biggest one is salt. And it's always educational when I have this talks with patients, just discussing the amount of hidden sodium that's in foods. So I would say the biggest impacted diet would be taking a look at what their normal diet would include and what their sodium content is. And it's just really shocking the amount of hidden sodium that's in processed foods. So that would be my biggest recommendation. If you wanted to make the biggest dietary change in your blood pressure, would be to start reducing the amount of sodium that you intake in your diet.
Great. And then there's a question about lipoprotein, LPA1 testing. I don't know if you could speak to that.
Yeah, so many of you, when you have your blood test performed, will have what's called the standard lipid profile, which gives you things like your total cholesterol, your HDL, your LDL, your triglycerides. But there's also more advanced cholesterol blood testing that can be performed, which breaks down the subparticles of your cholesterol to give you a little bit more detailed information. And some of these cholesterol particles, like Lp(a), tend to be more what we call atherogenic, which means more prone to forming plaques or obstructions in your blood vessels and may direct your physician to be more aggressive in your care. There's a number of panels that we have available at Barton that if you talk with your primary care physician about, or your cardiologist or whoever you see, that can order to give you that detail if that's something you're interested in.
Okay. And then again, I know you covered this just at the end here, but just again, the top supplements that you would recommend that you believe are effective.
Well, I think there's a few that come up again and again in cardiology. And one is CoQ10. And I know this isn't related to hypertension, but I use CoQ10 in people who take statins, medications to control your cholesterol, because I think it can help reduce the side effect of muscle cramping and muscle aching with those medications. So I do encourage patients to take that, especially if they're on a higher dose of a statin medication. I do encourage my patients with coronary artery disease, whether you've had a stent put in or prior heart attack, to take at least 1,000 milligrams a day of fish oil, because that can be associated with a reduced risk of cardiovascular death. Outside of that, if we're talking about hypertension, I think that the only one that I would tell you I have seen benefit from, and this is not entirely specific, I'm not an osteopathic physician, but I have seen the best results with beet supplements.
Right. I see one more, and I'll just remind folks that you can ask questions in the Q&A box or the comment box. But one question that was just asked was saying that they drink a lot of water and that their sodium is always low, but they eat a lot of salt. Is there a correlation there?
Well, that's really funny. So when your sodium level is low in your blood work, it's not necessarily a reflection of your salt levels, it's a reflection of your fluid levels. So that condition is called hyponatremia. And when we evaluate hyponatremia, there's an algorithm that we follow to determine why that's low. And it has to do with, do you have too much water in your body? Do you have not enough water in your body? Or do you have just the right amount of water? So I would answer that by saying that if your sodium levels are off, it's not always the right thing to do just to eat more salt to correct that. So that I would say it's that individual, maybe make an appointment with your primary care so they can take a look at the low sodium to help clarify which one of those buckets, too much water, just the amount of water, not enough water, that it's falling in to help correct.
Great. I think our supplement question spurred a couple more, so some
Okay.
more have rolled in. The first one, it was CoQ10 helps to reduce cholesterol as well, or is it just more for muscle discomfort?
Yeah, I've never seen any significant cholesterol reduction from it. And other people, other providers may have different uses that they feel it's important for, and I don't want to discredit that. But to me, the only time that I really ask patients to take it, and I try and be sensitive. I mean, a number of patients have 3, 4, 5 pharmaceuticals they have to take, and I try and limit the amount of things that they have to take on a daily basis. But if you're taking one of the higher intensity statins like Lipitor or Crestor, and you're on higher doses of that medication, then there is an increased risk of musculoskeletal side effects related to the medication, which can be muscle aching, muscle cramping, Charlie horses, muscle weakness. And taking 200 to 300 milligrams of CoQ10 a day, along with the fish oil in that situation, can help to reduce the risk of those side effects of the medication. Because in many of our populations, those medications can reduce your risk of having a recurrent heart attack, stroke, or cardiovascular death by 40%.
Okay. And there's a question about what do you think of red rice yeast and
Red yeast rice. Okay, I probably should
monoclonal?
have, that would have been, if we were doing a cholesterol talk, I definitely would have put that one in there. I should have mentioned that. So red yeast rice is a homeopathic version of a statin. So red yeast rice contains a molecule in it, which is called a monocolin. I think it's monocolin K. And that monocolin K is molecularly similar to lovastatin. It's equivalent to about 5 milligrams of lovastatin. And I have seen this work. It's not a significant drop in your blood pressure. So if you were borderline having a high LDL cholesterol and wanted to try and drop it naturally, sometimes it can be effective. But it doesn't really provide, I would say, more than a 10 to 15% decrease in your cholesterol. The problem is you have to find the right formulary that contains the monocolin K, the active ingredient in it, to obtain the benefit. And I've seen a lot of people that have bought them over the counter in grocery stores and paid a lot of money for them, and it hasn't done anything. And some people that have had different preparations that it's worked. So I think there's just some variations into the efficacy, but the theory is that it's similar to lovastatin, one of our statins that we use.
Okay. This question is about HDL. Their HDL has been abnormally high for years. Can you speak to cholesterol or HDL ratio? This person's is 1.9 for reference.
Well, that's great, right? So, there's a good cholesterol, which we call your HDL. And your HDL cholesterol circulates around in your body and picks up your bad cholesterol to the LDL, that's the bad one, and takes it to your liver to be metabolized. So when you have a high HDL level, that can almost be cardioprotective because you have more of these HDL molecules out circulating around to pick up the LDL, the bad one. The LDL is the one that's responsible for blocking the arteries and to eliminate it from your body. So that's fantastic. In fact, people that are avid exercisers will tend to have higher HDLs in response to that and lower LDLs. So that's great.
Okay, and maybe I misrepresented it. They're also saying that they're on Crestor, that their cholesterol is 190. So I'm not sure if I represented it
Well,
correctly, but hopefully.
yeah, Well, I think it would be important, and I'd be happy if that individual would like to take a look at their lipid profile. I mean, your cholesterol is just a piece in the puzzle, right? So when we make a determination of who needs to take Crestor and who doesn't, what we do is we calculate your 10-year risk of having a heart attack, stroke, or cardiovascular death. And that 10-year risk is a function of your age, your gender, your smoking history, your blood pressure, are you diabetic, your cholesterol, and we calculated all that. And if you come up with a value of greater than 7.5%, then we tend to say that you're at higher risk and statin therapy may be warranted. So there may be a little bit more to that equation than just the HDL.
Great. Well, I think that's all the questions. If you have one, as I wrap things up, I will be happy to ask it. But just as kind of in conclusion and some housekeeping, we really appreciate everyone being here. This webinar has been recorded. So if you want to reference back to it, there's so much good information. You can find it on our YouTube channel, and I will post it to our Facebook channel as well. And there will be a post webinar survey. We'd love to hear your feedback. How did we do tonight? What topics would you like to see in the future? It helps us determine future topics. So I'm getting some great thank you so much. We'd love to hear that feedback in the survey as well. And I believe that's all the questions we have. So Dr. Young, thank you so much for the great presentation tonight. I really appreciate it. I did include the link in the chat box as well on the blood pressure clinics. So check that out if you want to find out more information. I think with that, we'll say have a good rest of your evening. Thank you again, Dr. Young.
All right, you're very welcome. Thank you.